introduce myself so that you know who I am and where I'm from, because I think that's important that you know that in order for you to be able to understand my perspective. I am Sue Masel. I am the Medical Superintendent at Goondiwindi Health Service. I'm also a general practitioner in private general practice in Goondiwindi. I'm a rural generalist practicing obstetrics and anaesthetics in Goondiwindi. I have 4 young children. I am the President-elect of the RDOQ for next year, and I'm married to another GP obstetrician. So we live and breathe medicine in our household. I will preface my address this morning by mentioning that I'm going to be just presenting a rolling slideshow of images of people and events from our unit over the last few years. It runs for about 4 minutes, so if it starts to run through again, then my time is probably just about up. I'd like to thank the Queensland Centre for Mothers and Babies for hosting this event today. I think it's really encouraging to see how many attendees we have, and I think that speaks to the level of interest in regenerating rural maternity services in the state of Queensland. I can only speak from my experience of working in one continuity of care model in Goondiwindi, but I do think that there have been some lessons learned for us, which may be useful for other people to hear, and I understand that other people are interested in what we're doing. I also think that what works well in Goondiwindi will not look the same as what will work well in other rural towns, and as John Hall mentioned earlier, if you've seen one rural town, you've seen one rural town. So for what it's worth, this is my perspective on collaboration in a continuity of care midwifery model. I need to be very clear at the outset that ours is not a midwifery-led model. Ours is not a medically led model. It is a genuine collaboration between a group of midwives in a Know Your Midwife continuity model, working with a group of GP obstetricians who are also practicing rural generalist skill sets in the same community, along a set of agreed protocols in a very happy way. I decided to try and think of a couple of challenges that we face in providing maternity services in a rural area and focus on what difference I think the continuity has made to those challenges for us. So challenge one I've chosen is distance to care. Our patients face distance to primary care. A lot of them live 100 kilometres or more out of town, and yet we are their closest health service. They face even bigger challenges in accessing secondary and tertiary care when they need to leave our community. In our unit, the Know Your Midwife framework allows maternity care to become the core business of the caseload midwives. The doctors and midwives participate together in the provision of maternity care using agreed protocols. The team approach provides an evidence-based framework where each member brings what they do best to the table. The whole team becomes responsible for the outcomes. Within the team, each woman has a midwife who she gets to know very well. This midwife becomes her first point of contact when problems crop up along the way. The scenario of, I live 100 kilometres out of town, my waters have broken, I have 2 children at school and a husband on a tractor, becomes a less scary proposition when you can call someone you know really well for advice. And I'm sure that that's leading to less roadside births. The second challenge I will focus on is the need for practitioners to maintain a broad skill set. We need generalist midwives in our unit who can take a woman on a journey, midwife with woman, through antenatal care, through interpartum care, through postpartum care, and in some cases visiting at home if we've achieved an early discharge, in other cases being the person to take that woman to theatre when everything goes wrong and we're in theatre at 2 o'clock in the morning doing the caesarean. We need generalist doctors. We need doctors who are able to practice an emergency medicine skill set or a general practice skill set for most of their day, but have an obstetric skill set to contribute and are called upon where necessary. When the members of the team learn to depend on each other, it becomes the business of every team member to participate in and help to provide skills maintenance activities. If any member on the team can say, I need to know that you are safe if a shoulder dystocia happens when I'm not there, then together, we drill emergency skills as a team to make sure that that's the case, and every team member benefits. Challenge 3 is the ability to deliver equivalent outcomes to those being achieved in metropolitan units. So we're a group of non-specialists attempting to deliver an excellent quality of service in an environment where we deliver less than 200 women per year. How can we achieve that? We need to have some trust in and ability and willingness to use evidence-based statewide guidelines. We need to understand the district protocols so that we can assist our women to navigate their way through the system when they need to leave our health service or in helping them to access our health service. We need to have really good communication links with the secondary and tertiary hospitals we rely on for backup. We're blessed to have the assistance of the Flying Obstetric and Gynaecology Service out of Roma, who are available 24 hours a day for telephone backup and advice. And thanks to Minister Springborg's commitment to increase the flying hours of the FOG service, they're even more available than they ever have been before to assist in a physical sense when there's a crisis on the ground. I think it's very important too to think about risk stratification, and I think it's certainly the case in Goondiwindi that the referral of women who are beyond our service capability has been facilitated in getting them to care by the fact that they have a known midwife. Those midwives are very involved in making sure that women don't take Minister Springborg's wife's option and go underground when the time comes if they don't like the decisions that have been made about their risk category, that everybody knows what's happening and there's a plan and the social worker's been involved and the midwife's been involved and the woman understands why and respects the decision and attempts to help us make it happen. My fourth challenge is that we have small numbers of practitioners providing an around-the-clock service coverage. Continuity of care models, I am sure, share the burden of service coverage in a more sustainable way. I was only having a conversation with one of our midwives 2 days ago, and she said to me, you know, it wasn't until we became caseload midwives that I really understood the burden of call, being on call, what it means to my personal time, my private life. Rural GPs have known that since day dot. And I think it's completely appropriate that the first point of call for a woman in our service is her known midwife, who will usually make the initial assessment and will definitely involve the GP obstetrician if that's appropriate and required. So I have participated in the provision of maternity services in Goondiwindi for 12 years and in a continuity of care model for the past 4 of those years, and I can tell you now that I don't want to go back. So thank you again for inviting me to share my perspective, and I'll be pleased to join the panel discussion later to answer questions.